So today our topic of discussion is regional anesthesia. So we are going to discuss about regional anesthesia. So first of all, we must have to know what is a regional anesthesia. Please remember, regional anesthesia, in this we are going to deposit the drug. We are going to deposit the drug near the nerve fibers. Okay, we are going to deposit the drug near the nerve fibers, and now it is going to reversibly blocks the autonomic sensations, sensory and motor, your nerve fibers. Okay, so this is your regional anesthesia. Please remember, in regional anesthesia the patient will be in conscious state as compared to general anesthesia. In general anesthesia the patient is in your unconscious state. Okay, so first of all, which type of regional anesthesia we are mainly using? We can use it locally in the form of local anesthesia. We can use it as a central neuroaxial block. Please remember, central neuroaxial block, it can be spinal anesthesia and it can be your epidural anesthesia. Okay, so if you are giving the anesthesia in the subarachnoid space, in the vertebral column, this is your spinal anesthesia. If you are giving the anesthesia in the epidural space, in the vertebral column, then it is your epidural anesthesia. And then we have peripheral nerve blocks also. Okay, peripheral nerve blocks also. So I can block any peripheral nerve, for example sciatic nerve, femoral nerve, axillary nerve, any nerve, etc. We can, for this is known as peripheral nerve block. Okay, so first of all we are going to discuss about the local anesthesia mechanism of action. So what is the mechanism of action of local anesthesia? Please remember, it is going to reversibly blocks the sodium channels. Okay, please remember, it is a very important MCQ, and this MCQ was asked in your examination. If they are going to ask you local anesthetic drugs, they are going to block which channels? So primarily it is going to block your sodium channel. Okay, so it is primarily going to block the sodium channels. Okay, but it can also blocks the other positive ion channels like potassium, calcium and NMDA channels also. Okay, so please remember this point. This is very important MCQ which you must have to remember. And when it is going to block the sodium channels, it will block the sodium channels from the cytoplasmic side. Okay, from the cytoplasmic side, that is the inner part. And when they are blocking the sodium channel, please remember, the local anesthetic drugs, they always acts on the active nerve fibers. Okay, they will always act on the active nerve fibers. Okay, so action of local anesthetic drugs, it is based on active nerve fibers. Okay, now sometime what we can do, because local anesthetic drugs, they cause vasodilation, and if they causes vasodilation, it can enter into systemic circulation and it causes systemic toxicity in the patient. So sometime along with local anesthetic drugs, we can add adrenaline also, most commonly, or any vasoconstrictor. Okay, but most commonly is the adrenaline. So when you are adding the adrenaline in a form of vasoconstrictor, what it will do, please remember, it will decrease the systemic toxicity in the patient because of vasoconstriction. Now the drug which you deposit in that area, it is going to remain in that area and it is not going to absorb in the systemic circulation, so it will decrease the systemic toxicity. It will prolong the duration of the drug. Okay, it will have faster onset. Okay, and it can have better intensity also. Okay, intensity also for the drug. For example, if you are giving lignocaine to the patient, please remember lignocaine alone we can give only 3 mg per body weight in kilograms in kg. Okay, but when I am adding lignocaine along with adrenaline, I can increase my dose up to 7 mg per body weight in kilograms. Okay, but please remember you cannot add this local anesthetic drugs along with adrenaline to all the patients. So sometimes please remember that local anesthetic plus adrenaline, it will cause what? It will cause increase pain at the site of injection. Okay, and second important point, this it is contraindicated in cardiovascular patients. Contraindicated in cardiovascular patients. Number 2, patients who are taking tricyclic antidepressant drugs. Okay, and you cannot give this injection at the end arteries. Okay, for example, like fingers, toes, etc., etc. You cannot give there in the end arteries. Okay, so end arteries, it is contraindicated because it will cause the ischemia and necrosis of the fingers and toes, because these are end arteries. There will be no you can say connection or blood supply to that area. It is contraindicated in cardiovascular patient who are taking tricyclic antidepressant drugs. So in these you are not going to use this local anesthetic along with adrenaline. The increase in pain at the site of injection, it can be reduced by, please remember, it can be reduced by adding sodium bicarbonate. Okay, when you add sodium bicarbonate, it will reduce the pain. Okay, so sometimes we can add sodium bicarbonate also. So please remember, whenever there is an infected site, there will be acidity, it will increase the pain, and when you are adding sodium bicarbonate, it will make it more alkaline, so it will reduce the pain. And the same actions will be that it will also decrease when you are adding sodium bicarbonate. It will also prolong the duration. It will also lead to faster onset of the drug. It will also lead to better intensity, and it will also reduces the pain at the site of injection. Okay, so these are the points which you must have to remember. Then you must have to remember grossly the nerve fibers. So please remember, nerve fibers are grossly are of 3 types. Okay, it is A, B and C nerve fibers. Okay, A nerve fibers are further divided into alpha, beta, gamma and delta nerve fibers. Okay, B nerve fibers are your pre-ganglionic autonomic nerve fibers. C nerve fibers are your post-ganglionic autonomic nerve fibers plus pain also. Okay, so please remember the local anesthetic drugs are sensitive to B nerve fibers, then C and then A. Okay, so this is from higher sensitivity to lower sensitivity. And if you talk about the blockage, then it will be first it will be autonomic, followed by sensory, and then followed by motor nerve fibers. Okay, so that's why if I reduce my dose, of local anesthetic drugs, what will happen? It will only blocks the autonomic and sensory nerve fibers, but motor remains intact. So when motor remains intact and it only blocks autonomic and sensory nerve fibers, it is known as differential block. Okay, it is known as differential block. And please remember, you can use this differential block for painless labor. Painless labor, for analgesia in the patient post-operatively. Okay, so you can use it there. So please remember these important points. And if you talk about the sensations, so sensations will be, first there will be temperature, that is the cold sensation, followed by pain, followed by touch, and followed by proprioception. Okay, and please remember, recovery will be from the back. So recovery will be from the back. It means first patient will have proprioception, followed by touch, followed by pain, and then the temperature or cold sensations. Okay, now coming into the local anesthetic drugs classification. So local anesthetic drugs are divided into two groups. What are the two groups? One is the ester group and second is the amide group. Or you can remember, ester drugs will have only one eye or single eye. Amide group is having double eye. Okay, for example, see here, cocaine, procaine, chloroprocaine, okay, benzocaine, tetracaine. So in all these drugs, you can easily see they are only having single eye. So if there is single eye, this is an ester group. If this is a double eye, for example, lignocaine, prilocaine, bupivacaine, ropivacaine, okay, levobupivacaine. So all these drugs are having double eye. See here. So if the drug is having double eye, it is your amide group. If the drug is having single eye, it is your ester group. Okay. Now see here. First of all, ester group plus cocaine. Ester group except cocaine. This is your MCQ. Ester group except cocaine. This one. Okay. So ester group except cocaine are metabolized by pseudocholinesterase enzyme. Okay, so when they are going to metabolize by pseudocholinesterase, there will be formation of PABA, and this PABA can cause allergy to the patient. It can causes allergy to the patient. Okay, it can causes allergy to the patient. So this is your MCQ. So cocaine is not metabolized by pseudocholinesterase enzyme. So in cocaine there will be no formation of PABA. So it will not going to cause any allergy to the patient. Okay. So see here, cocaine and amide group, they are going to be metabolized by liver. So when they are metabolized by liver, please remember there will be no formation of PABA, so there will be no allergy to the patient. Okay, no PABA, no allergy to the patient. And mostly we are using amide groups. Okay, so when you are using amide groups, please remember, if patient is having liver dysfunction or patient is having shock, in those patients I must have to reduce my dose of local anesthetic amide group. I have to reduce my dose, okay, because their metabolism is by liver. So in liver dysfunction, I must have to reduce my dose. Shock, already the blood supply to the organs is compromised. So in shock patient also, we must have to reduce our dose because it can cause systemic toxicity in the patient. Okay. So first drug which we are going to write is about the cocaine. So see here, cocaine. What are the important points? Please remember, it is metabolized by liver. So there will be no PABA, no allergy. Okay, it is the first LA used. First LA used is cocaine, and it is a naturally occurring LA. Naturally occurring LA, it is your cocaine. Okay, and very important point, please remember, it is the only LA which causes vasoconstriction. The only LA which causes vasoconstriction, answer is your cocaine group. Okay, so it has a sympathomimetic activity. Sympathomimetic activity. Cocaine, sometimes we can add adrenaline plus sodium bicarbonate. So when we add all these three things, it is known as Moffat's solution. Okay, it is known as Moffat's solution, and you can use it in nasal surgeries in the form of sprays. Okay, it will cause vasoconstriction there. So these are the important points of cocaine. Okay, chloroprocaine, please remember one point only. Chloroprocaine, ester group, metabolized by pseudocholinesterase enzyme. So it is the most shortest acting. Okay, and most commonly it is used in daycare surgery. So in daycare surgery, I can use chloroprocaine. Okay, next you must have to know points about benzocaine and prilocaine. Okay, benzocaine 1I, so it is ester group. Prilocaine, it is having 2I, so it is your amide group. Okay, their side effects is methemoglobinemia. Please remember this point, very important. Okay, this is the point of chloroprocaine. Okay, then you must have to write important point in relation to lignocaine. This is the most important drug which you must have to remember. Number 1 point, it is intermediate acting. Its action is around 40-45 minutes. Amide group, metabolized by liver, so there will be no PABA, no allergy. Okay, no PABA, no allergy. Please remember, it is the safest and most commonly used local anesthetic drug. It can be given intravenously. So when you give it intravenously, it is known as intravenous regional anesthesia, and this is known as Bayer's block. So please remember, in Bayer's block, I can give local anesthetic drug in the form of what? Lignocaine. Okay, but very important MCQ, in Bayer's block, contraindicated is bupivacaine. So bupivacaine is contraindicated in Bayer's block. Okay, but lignocaine you can give intravenously, and when you are going to give it intravenously, it is known as intravenous regional anesthesia. You can also use lignocaine in the form of 2%, 4%, and 10% spray. Okay, spray to anesthetize the airway during awake intubation. Okay, so you can use it there also, lignocaine. Okay, so these are the points which you must. And dosage of lignocaine I already explained to you. If you give it alone lignocaine, then the dose will be what, 3 mg per kilogram of body weight. But if you add lignocaine plus adrenaline, then the dose will be what, 7 mg per kilogram of body weight. Okay, clear to everyone? Here we must have to okay, first we will write points about the bupivacaine. So bupivacaine, see here, it is having what? It is having 2 I's. So it is your which group? Amide group, metabolized by liver, no PABA, no allergy. Okay, most commonly used in differential block. We most commonly using bupivacaine. And very important MCQ which you must have to remember, that it is the most cardiotoxic local anesthetic drug. Most cardiotoxic local anesthetic drug. Answer is bupivacaine. That's why they now make the isomers of the bupivacaine in the form of ropivacaine and levobupivacaine. Okay, so to reduce their cardiotoxicity. So the most cardiotoxic local anesthetic drug, answer is bupivacaine. And one important point of bupivacaine, please remember, it is contraindicated in Bayer's blocks. In Bayer's block, you are not going to give bupivacaine. Okay. Next important point, you must have to remember that that is the amla or amla cream. So what is amla cream? Please remember, it is a combination of lignocaine and prilocaine in the ratio of 1:1. Okay, so it is a eutatic mixture of local anesthetic drugs. Okay, where you are going to use for skin, for venipuncture in infants. Okay, infants you are going to use it. Okay, amla cream. But please remember, it is contraindicated in neonates, contraindicated on the mucous membrane, and if there is any breach or damage in the skin continuity, then you are not going to use it. Okay, please remember it. Very important point. You must have to know this. Okay, amla cream. So it is a combination of lignocaine plus prilocaine. Okay. Okay. And in the last, we must have to understand very important topic that is known as last. So what is last? Last is local anesthetic systemic toxicity. Okay, local anesthetic systemic toxicity. So local anesthetic systemic toxicity in the patient can cause the symptoms in relation to your central nervous system and cardiovascular system. Okay, please remember, cardiovascular system symptoms are your life threatening. They are your life threatening. So patient can develop arrhythmias, patient can develop cardiac arrest also. Okay, CNS, central nervous system, patient develop apprehension, patient develop seizures, patient develop, you can say, tinnitus, perioral numbness. Okay, so these are the symptoms, but they are not life threatening. But cardiovascular system toxicity can lead to arrhythmias and lead to cardiac arrest in the patient. Okay, so what you are going to do, so how you are going to manage this patient? So management is, please remember, management is number one, stop the local anesthetic drugs, manage the patient symptomatically. If patient is having cardiac arrest, give CPR to the patient. Okay, and CPR, please remember, if patient is having no breathing, no pulse, then you have to give CPR to the patient. No breathing, no pulse, then you are going to give CPR to the patient. And there will be ratio 30 into 2. Chest compression 30. 2 is your what? Rescue breathing. Okay. And in CPR, the protocol is CAB. First is circulation, followed by airway, followed by breathing. That's why you are giving 30 chest compression, then 2 rescue breath. This is for the adults. Okay, but very important MCQ, that the drug of choice for last is 20% intralipid emulsion. Please remember it, very important. So the drug of choice for the treatment of local anesthetic systemic toxicity, answer is 20% intralipid emulsion. Okay, because this lipid emulsion, it will not allow the drug because the local anesthetic drug which you give to the patient, it is going to attach to the sodium channel, so it will absorb the local anesthetic drugs and take it away from your sodium channels. Okay, so this is your very important MCQ. Please remember it. Drug of choice for patient with local anesthetic systemic toxicity, answer is last. So this is your topic of local anesthetic drugs. Next time we will discuss about central neural axial.